This is the beginning of part 3 on the lecture Imaging of the Cranial Nerves. The fifth cranial nerve is very complicated, and we're going to spend a lot more time on 5 and 7 than we do on the other cranial nerves. The trigeminal nerve arises from the lateral aspect of the pons and goes straight forward. It just drives straight forward, front and back, headed straight towards that porous trigeminus, which leads into Meckel's cave. Meckel's cave is where the Gasserian ganglion lives, and it's worth talking about in more detail. The Gasserian ganglion gives rise to 3 branches: the ophthalmic nerve, the maxillary nerve, and the mandibular nerve, that are almost always referred to by their abbreviations V1, V2, and V3. In this case, V meaning the Latin numeral 5 for the fifth cranial nerve, so that's fifth 1, fifth 2, and fifth 3. Here's that fifth cranial nerve coming straight forward off of the lateral pons. It's that direct anterior-posterior direction, and it's big size. This is a very large cranial nerve. Those are what will allow you to identify the fifth cranial nerve. Straightforward. This little gap right here is the porous trigeminus, and then we're into Meckel's cave right there. So when we see lesions that run that precise course from the lateral pons forward through the porous trigeminus and into Meckel's cave, we can assume that they arose from the trigeminal nerve, as this one did. This looks just like a schwannoma you'd encounter anywhere else, but because of its location and course, we can deduce that it's a schwannoma of the trigeminal nerve. Here's another example. This is neuritis of the trigeminal nerve. You can see it's got that characteristic course. Here is the normal nerve on the other side. That characteristic course going straight forward off of the lateral pons right into Meckel's cave. So that tells us that the anatomic structure we're looking at here is the trigeminal nerve, and it's enhancing. It's a neuritis. This happens to be Lyme's disease. Remember that the trigeminal nerve, although it's predominantly a sensory nerve, does have a motor component, and that motor component is predominantly innervating the muscles of mastication and a few other things like the anterior belly, the digastric, and the mylohyoid muscle, and some stuff in the ear. But the sensory component is the large component, but there is this tiny little additional rootlet that comes off separately from the brainstem and joins in. These two join together to form a single trigeminal nerve, but they emerge as a large sensory and a small motor branch off of the lateral pons. We can see this on axial images as well. The arrowheads are pointing to the smaller motor branch of the trigeminal nerve, and you can see it accompanying the sensory branch right through the porous trigeminus there. Let's take a moment to focus on Meckel's cave. Meckel's cave can be identified anatomically because it lies inferior, posterior, and lateral to the cavernous sinus. It is predominantly filled with cerebrospinal fluid. There's open communication through the porous trigeminus from the prepontine cistern right into Meckel's cave. Nothing stopping the flow of CSF there. So it's predominantly filled with CSF, and that's why it has CSF intensity or attenuation, depending on which modality you're looking at. Although obviously there is also the trigeminal nerve in there. Once the trigeminal nerve passes through the porous trigeminus and enters into Meckel's cave, it splits off into a myriad of small rootlets that form a web throughout Meckel's cave and then coalesce anteriorly into the Gasserian ganglion, which lies along the anterior aspect of Meckel's cave. It's often hard to identify because it's not surrounded by CSF. It's just plastered up. The Gasserian ganglion is plastered up against the anterior aspect of Meckel's cave. This anatomy is really important because Meckel's cave is a bit of a crossroads for all of these different branches to come together for perineural spread. Here's a coronal image, heavily T2 weighted, right through Meckel's cave. And what it shows us is the shape, the anatomic shape of Meckel's cave, but it also shows us that web of small rootlets that are traversing Meckel's cave and are going to coalesce into the Gasserian ganglion anteriorly. There are a lot of things that can cause enhancement within Meckel's cave, and they kind of look a lot alike. So I'm going to go show several examples of this. Here's metastatic disease within Meckel's cave. You can see, of course, a lot of leptomeningeal disease in the posterior fossa as well, but Meckel's cave on both sides, not filled with CSF, right? Maybe a little bit left there, but not filled predominantly with CSF, instead filled predominantly with enhancing tissue. This happens to be breast cancer metastasis to Meckel's cave. Schwannomas can arise in Meckel's cave. Obviously, these are trigeminal schwannomas, or at least a schwannoma of one of the branches, and it has a rounded configuration. Here's the normal Meckel's cave filled with CSF, and here is the expanded Meckel's cave instead filled with enhancing tumor, in this case a schwannoma. Same thing in coronal. You can see the normal Meckel's cave on this side filled with CSF, and here is the enhancing tumor on the affected side. Here's inflammatory disease. This is sarcoid involving Meckel's cave bilaterally, right? This is Meckel's cave, should be filled with CSF, instead filled with enhancing tissue. This looks exactly like the Mets from 2 images ago. That's why I'm showing all of these examples in order. Here's Lyme disease in Meckel's cave. This is the unaffected side. You can see appropriately filled with CSF. Here's the affected side, inappropriately filled with enhancing soft tissue. It's really enhancement of the nerve itself. You can actually see other cranial nerves involved here as well. Yeah, so it looks just like all of the other ones. So these enhancing masses and inflammatory lesions within Meckel's cave kind of look a lot alike. The clinical history is, of course, going to clue you in to a precise diagnosis. As a very general overview, the trigeminal nerve is primarily responsible for sensory innervation to the face and secondarily responsible for muscular innervation to the muscles of mastication and a few smaller muscles such as the mylohyoid muscle and the anterior belly of the digastric, and a couple of other things as well. Now let's focus on each of the branches. The first branch of the trigeminal nerve, V1, is the ophthalmic nerve. It runs from the Gasserian ganglion into the cavernous sinus and then up through the superior orbital fissure along with the third cranial nerve, and then it runs along the roof of the orbit, along the supraorbital canal, and emerges along the roof of the orbit, along the supraorbital rim as the supraorbital notch. Usually it's not a complete foramen, it's an incomplete foramen, so we refer to it as the supraorbital notch instead of the supraorbital foramen. It's very hard to see the ophthalmic nerve on MRI unless it's abnormal, so I'm showing you an example of perineural spread along the first branch of the trigeminal nerve, and you can see that there's an extra focus of enhancement right along the roof of the orbit, right where we'd expect the supraorbital canal to be running. The second branch of the trigeminal nerve, the maxillary nerve, emerges from the Gasserian ganglion and heads straight into the cavernous sinus. From there, it runs through the foramen rotundum to emerge into the inferior orbital fissure, and then into the orbit along the infraorbital canal that runs along the floor of the orbit. It emerges into the face through the infraorbital foramen just below the orbit in the cheek. There's a very important relationship between V2 and the pterygopalatine fossa. The V2 runs right over top of the pterygopalatine fossa, not into it, over top of it. It sends some communications down to the pterygopalatine ganglion, but it is not dead-ending into the pterygopalatine fossa like Vidian's nerve does. That relationship is shown on this classic coronal CT image. The reason that this is a classic is that you're going to be asked to tell which of these two round objects is which. One of them is foramen rotundum. The other is Vidian's canal. So which is which? If you remember that V2 is going over top of the pterygopalatine ganglion, whereas Vidian's nerve is dead ending into the pterygopalatine ganglion, then it becomes a lot easier. Vidian's nerve is going to dead end into the pterygopalatine ganglion a few cuts forward from this, and foramen rotundum here carrying V2. V2 is going to skim over the top of that ganglion. Notice that the sphenoid sinus will sometimes extend out as a lateral recess between those two objects. That's all normal variance. Okay, but the important thing here, foramen rotundum, Vidian's canal. Here's an example of perineural spread along the second branch of the trigeminal nerve through foramen rotundum. You can see this enhancement coming straight forward to back. Foramen rotundum is anatomically oriented straight anterior posterior, which makes it somewhat easier to identify on axial images. You can see that this tumor has spread all the way back to the Gasserian ganglion and is impinging on the front of Meckel's cave. That's the normal shape, and here impinged on the affected side. The third branch of the trigeminal nerve is the mandibular nerve. It runs straight down from the Gasserian ganglion into foramen ovale. From there, it emerges into the infratemporal fossa, and it has two important branches, the auriculotemporal nerve and the infraalveolar nerve. Most of the nerve is continuing as the infraalveolar nerve. It's headed out towards the mandible, goes into the mandibular foramen, and runs the length of the mandible. But the auriculotemporal nerve is an extremely important branch. It branches off and runs behind the mandible and then through the parotid gland and innervates the skin of the lateral cheek overlying the parotid gland. This is really important because it is an alternative mode of perineural spread for tumors that arise within the parotid gland. We think about tumors in the parotid gland going up the facial nerve, and that's the more common thing for them to do. But here's an alternative pathway for them to go intracranial. They can instead run along the auriculotemporal nerve into the infratemporal fossa, join V3, come up through foramen ovale, and then into the intracranial vault. Here's an example of perineural spread along the third branch of the trigeminal nerve. Be very careful when you're interpreting these coronal post-contrast imaging. You should be able to see a lot of venous enhancement right around foramen ovale. That's normal as long as you can still see the nerve down the center, right? So here's a non-enhancing nerve down the center and all this venous enhancement around it. That's the normal side. This is abnormal, it's expanded, the whole thing is enhancing through and through, no spared nerve down the center. That's perineural spread, okay? Be sure you know what the normal side looks like so that you don't accidentally call all of this venous enhancement perineural spread. Here's a mass that arose within the parotid gland. And this is an aggressive tumor. It happens to be adenoid cystic carcinoma. You might expect this tumor to run along the facial nerve and go intracranial. But instead, this nerve has taken a different path. This tumor has taken a different pathway. It is running medially behind the ramus of the mandible to join up with the mandibular nerve in the infratemporal fossa, and from there it will come up through foramen ovale, just like on that last picture, and into Meckel's cave. So this an extremely important alternative pattern of perineural spread for tumors of the parotid gland. That's the auriculotemporal nerve. Although the trigeminal nerve is predominantly a sensory nerve, there is a motor component, and when the trigeminal nerve is injured, you get denervation, atrophy of those muscles. So if you look on the right here, these are robust, normal-looking muscles of mastication, but on the left, they are diminutive and flimsy, and they have abnormal signal centrally. That's the look of denervation, atrophy. Denervation atrophy becomes a real problem in the acute phase of denervation in the setting of tumor because denervated muscles begin to enhance. That enhancement can easily be mistaken for tumor spread. Here's an example where almost all of the enhancement that you're seeing here is from denervation atrophy of the muscles of mastication and not from tumor itself. One clue is the configuration of the enhancement that is along the muscles. Another is the preservation of the tendon, as you can see here in the temporalis tendon. Those are some of the clues you can use, but you need to get used to this appearance in order to avoid this potential error of a false positive of tumor spread. Trigeminal neuralgia is one of the most important diseases that we address in the trigeminal nerve. It also has a synonym, the historical term tic de la Rue. The treatment of trigeminal neuralgia has evolved substantially over the last few decades. Originally, we used to do surgical rhizotomies, just cut the nerve, but that doesn't work well because you get neuromas at the nerve endings and the symptoms just come back. For a while, we were doing glycerol rhizotomies. What happens here is that you put a needle up into Meckel's cave from foramen ovale, and you inject glycerol, which is a neurotoxic agent, and kill the nerve right there in Meckel's cave. We use tantalum as a labeling agent for the glycerol so that you can see it fluoroscopically while you are injecting it, and then you can identify it afterwards on CT scans. Radiosurgery was another innovation in the treatment of trigeminal neuralgia. In radiosurgery, you kill the nerve using radiation. And then the last thing on the list is microvascular decompression. This arose when we realized that the real problem in trigeminal neuralgia, in most cases of trigeminal neuralgia, was that there was an artery adjacent to the nerve, and the constant hammering of that artery against the nerve was injuring the nerve, and that was the cause of trigeminal neuralgia. If you put a little sponge, we call them Teflon pledgets, in between the artery and the nerve, then the artery can no longer harass the nerve and the trigeminal neuralgia will get better. That's the concept behind microvascular decompression. This is what a glycerol rhizotomy looks like after it's been performed. You can see the tantalum that accompanied the glycerol filling Meckel's cave. The reason we use the tantalum is so that you can see the glycerol fluoroscopically while it is being injected and ensure that it only fills Meckel's cave and doesn't spill back through the porous trigeminus into the posterior fossa and start killing nerves other than the trigeminal nerve. But this is what it looks like, and you should recognize this CT appearance of someone who has undergone a glycerol rhizotomy. There are a lot of important concepts in the imaging of microvascular decompression. The vascular compression of the nerve occurs only in particular portions of the nerve. Each of the cranial nerves has a resistant and a susceptible segment. The susceptible segments are those segments of the nerve where there is still myelination by oligodendrocytes. Once you transition to the point at which the myelin is supplied by Schwann cells, then you are in a resistant part of the nerve and adjacent arteries don't injure it anymore. You might think that that transition between oligodendrocytes and Schwann cells would occur right at the root entry zone of the nerve, but it's not true. That transition point is actually a few millimeters out in the cisternal segment of the nerves. For example, in the facial nerve, it occurs about 4 millimeters out from the root entry point, and in the trigeminal nerve, that transition point is about halfway between the root entry point and the porous trigeminus. So, if you see an artery that is adjacent to the trigeminal nerve, right at the porus acousticus, that's not causing the problem. That's a resistant segment of the nerve. But if you see the artery compressing the nerve closer to the root entry point, or even halfway, but closer to the root entry point, then that one is likely to be a source of pathology. And Teflon pledgets that are placed under surgery are the solution to this problem. It's very difficult to show a single picture that demonstrates what we're looking for in the setting of microvascular compression, because you need to be able to follow the artery along its course to ensure that what you're looking at is actually an artery and that it is a named artery. It's not just a crossing vein, which are frequently present. I show this picture. The red arrow is the trigeminal nerve itself as seen in coronal cross-section, and just above that is an adjacent tubular structure with the yellow arrow. That is the superior cerebellar artery. By far the most common artery to impinge upon the trigeminal nerve is the superior cerebellar artery. So that's what we're looking for on imaging prior to microvascular decompression. If you want to see this, you need to use very high resolution imaging. At my institution, we use 3-plane steady-state free precession imaging through the middle and lower cranial nerves. We do coronal, axial, and sagittal on every case in order to delineate these relationships. A very important thing to report on when you are looking at these images is to report on whether there is whether the artery is just touching the nerve, or whether there is any displacement of the nerve or distortion of the anatomy of the nerve. Those are progressive findings that make it more and more likely that that artery is the offending artery causing the trigeminal neuralgia. Honestly, we could do an entire lecture just on microvascular compression. Remember that patients with multiple sclerosis frequently have trigeminal neuralgia. This occurs when one of the demyelinating plaques is at or near the root entry zone of the nerve, or even extending along that first little segment of the nerve until the transition point. Remember that the nucleus of the trigeminal nerve is very complex, and it extends over a very long vertical distance in the brainstem, and so there's a lot of areas that are susceptible to a multiple sclerosis plaque. Now let's talk about the abducens nerve. The sixth cranial nerve begins at the anterior pontomedullary junction. It comes out right underneath the pons, and it goes forward obliquely at about a 45-degree angle towards the clivus. Once it reaches the clivus, it dives into its own personal little dural sheath up the back of the clivus called Dorello's canal. Once it reaches the top of the clivus, it emerges from Dorello's canal and enters directly into the cavernous sinus. It extends into the orbit, and it has one job. Its only job is to innervate the lateral rectus muscle of the eye. Here's where you're going to see it on axial imaging, steady-state free precession imaging here, and you're going to see it emerging just from the undersurface of the pons and coming obliquely forward towards the back of the clivus. It's a relatively small nerve. Now let's talk a little bit more about Dorello's canal itself. Dorello's canal is a fibrous sheath embedded in the back of the clivus. It is surrounded by dura, and it's a very tight space. So if you are looking for the bottleneck along the course of the sixth cranial nerve, you are going to find that bottleneck in Dorello's canal. Dorello's canal is relatively long. It runs most of the length of the clivus, and that's why the sixth cranial nerve ends up with, as they say, the longest intracranial course. Remember, the cisternal segment isn't particularly long, but if you count Dorello's canal, then it ends up with a pretty long intracranial course. Unfortunately, the nerve within Dorello's canal is not visible radiologically because it is not surrounded by CSF, but you can see the nerve as it enters the Dorello's canal. Here's an example of the sixth cranial nerve just edging into Dorello's canal. This little pocket is the canal itself, and there's the cranial nerve just headed into it. You can see the same finding on post-contrast imaging, where the nerve is breaking through this basivertebral plexus and extending into Dorello's canal at the bottom of the clivus. Once it's in the canal, you really can't see it anymore. So some of the pathology that we see with the abducens nerve includes an abducens schwannoma. Here we can see that there is a schwannoma that is in the lateral aspect of the cavernous sinus, and you can see it secondarily impinging upon Meckel's cave. If you looked at this and thought, oh, this must be a schwannoma of the fifth cranial nerve, that's understandable. The big clue here is, of course, this patient presents with a lateral rectus palsy. Petrus apicitis is a very important diagnosis to make. It's a very dangerous disease, and this infection can easily get out of control. One of the clues that you might be looking for this is a sixth cranial nerve palsy. Now, it's not obvious why these two would be related. Why would an infection in the petrous apex cause a sixth cranial nerve palsy? And the answer lies in Dorello's canal. So here is inflammation of the medial petrous apex. There's even a small abscess in one of the air cells there. You can see a lot of surrounding enhancement surrounding the petrous portion of the carotid artery there. So how does this affect the sixth cranial nerve? Well, remember that the sixth cranial nerve is running in Dorello's canal right here on the back of the clivus. So all of this inflammation spreads to the region of Dorello's canal. Remember also that Dorello's canal is a bottleneck, and so a little bit of extra mass there goes a long way in causing pathology in the sixth cranial nerve. When petrus apicitis causes sixth cranial nerve palsy, that has a name. It's called Gradinego's syndrome, and this is the imaging of Gradinego's syndrome. Here's another example where a mass can secondarily involve the sixth cranial nerve in Dorello's canal. Here we see a lobulated mass centered in the clivus. This is a bony lesion, but we know that Dorello's canal is running right up the back of the clivus, so it's not surprising that as this lesion expands, it might compromise the sixth cranial nerve. This happens to be a chordoma of the clivus. It is possible to have a congenital hypoplasia or aplasia of the sixth cranial nerve. That is called Duane syndrome, and the radiologic manifestations, it's sometimes hard to pick up the absence of the sixth cranial nerve, although it can be seen in the prepontine cistern. What's usually more evident radiologically is the atrophied lateral rectus muscle. Notice that the medial rectus muscle, because it's foreshortened, it's got no opposition from the lateral rectus muscle, it's foreshortened and thus looks thickened, while the lateral rectus muscle looks thinned and elongated in Duane syndrome, congenital absence of the sixth cranial nerve. This ends part 3 of the lectures on imaging of the cranial nerves.